everyone. First off, I'd like to introduce myself. My name is Stephanie Morton, and I serve as the Executive Director of Healthy Mothers, Healthy Babies. Many of you are familiar with our organization, but we're a statewide nonprofit that works to improve the health and well-being of moms, babies, and families in the state of Montana and beyond sometimes. One of the things that we have done and established as a niche for our organization is really helping to increase awareness about and advance workforce in the area of perinatal mental health in the state of Montana. We hold an annual conference each year. This year will be our 7th conference. We'll be in person for the first time in 4 years, which we're so very, very excited to be able to convene with everyone in that space. And that's what precipitated this presentation today. In the run up to our 7th conference, we know that it's always important to continue to lay out the fundamentals of any piece of education you're going to put out there, but most specifically perinatal mental health. We continue to push out into areas both within our networks that we know, our regular public health departments, our maternal child health experts across the state, medical, behavioral health, mental health professionals, and to advance this work and really centering ourselves again and again on the evolving data and that core piece of this puzzle, which we know that moms and parents have an incredible amount of stress, and even in the best case scenario. So we want to make sure that we're providing with them everyone with the best services and best access to services when they need it. To that end, we convene us all here today and get started with some of this 101 stuff. Just as logistics for today, this session will be recorded and then it will be posted later, so you'll be able to go back and access it. Or if you know somebody else in your agency or a friend or a colleague, whatever, who might benefit from this as well, please send it along. We're happy to get this out there as much as possible and hopefully get you started in that path towards advancing your perinatal mental health certificate or your perinatal mental health skills. One thing logistically, as we're going through this, Dr. Greenberg has asked if you have questions, feel free to throw those in the chat. If there are different things that are inspiring you or you have curiosities about, throw those in the chat, and throughout the presentation, I'll try and lift those up and address some of those questions. And so that will be a piece of this puzzle as well. Without further ado, I do think I'll just introduce our presenter today and we can get going. One other piece of logistics, down in the chat, you'll see our event manager, Anna Strange. If you are having tech troubles or anything along those lines, reach out to Anna. You can either use that chat function in Zoom, or she popped her phone number on there for texts or calls. So know that that's out there and going. Okay. So I want to turn the floor over to Dr. Samantha Greenberg. I met Dr. Greenberg, I think, for the very first time at the very first perinatal mental health conference that we hosted 7 years ago. And in that time, I think we have both, been doing work alongside folks and then crossing paths here and there. But I believe it was just earlier this year, which doesn't seem like long enough ago, I got to see her speak at another conference, and it was just so beautiful, to watch an expert here in the state of Montana be able to deliver such incredible information and be able to, walk up and reflect with her later, like, we've worked towards this. And I am so, so thankful for her dedication to advancing perinatal mental health in the state of Montana and training folks out of the family medicine residency program. And just having this kind of partner in the work. We haven't always had this. And so I'm just elated to be able to recognize someone here from the state of Montana and present this introductory piece of the puzzle. So I hope you all will help me in welcoming Dr. Greenberg.
Thanks, Stephanie. So, like Stephanie said, Samantha Greenberg, I'm a family medicine physician who does OB, and I am the site director for the rural training track in Kalispell for the family medicine residency of Western Montana, which means that most of my job is spent teaching physicians who hopefully are going to graduate and practice in our great state. And peripartum mood and anxiety disorders have become sort of a passion project of mine and a budding part of my practice. And yes, I met Stephanie for the very first time at the very first conference when I was new to this. And it's been quite a journey over the last 7 years. So I'm really honored to be able to be here and to speak um, and hopefully impart some knowledge on you all. So our objectives today are to describe the prevalence and impact of mood and anxiety disorders presenting in pregnancy and the postpartum period. We're going to hopefully identify risk factors and warning signs for development of peripartum mood and anxiety disorders. We're going to understand the spectrum of PMADS presentations in the postpartum period and hopefully increase our comfort with resources and linkage to treatment for patients with suspected PMADS. I don't have any disclosures other than I think whenever we're talking about a topic that we feel passionately about, I think it's helpful to talk about like where we've come from with that. So, like I said, I'm a family physician. I practice obstetrics, and despite that, felt like I did not know very much about peripartum mood disorders up until relatively recently. And I completed 5 years of training in obstetrical care and caring for patients with mood disorders of all sorts of flavors across the lifespan. And postpartum depression is something that was like on those list of things that you learn about, but not ever focused on, despite this sort of being my area of focus in medicine. And it wasn't until I moved to Kalispell and I myself was pregnant that my midwife said, "Oh, you also work in this field. Would you like to join a nonprofit she just started in Kalispell that was framed around caring for women with peripartum mood anxiety disorders?" And so I had kind of joined that organization and had heard about this conference. And from there, that's where I kept on diving more and more and more and realized this isn't something that is part of general medical education. It's not something that, we had been talking to our residents. It's not something that I think many people are getting comprehensive training in. And it became a passion of mine to help elevate that. And then I had my own experiences with my postpartum journeys with my children. And I think, as many things, when you have your own children, your perspective on a lot of things changes. So hopefully this presentation will sort of reflect a lot of that. I, the teacher at baseline, like to do a lot of case-based stuff. So we're going to explore this topic going through a few cases for 4 different people that we're going to meet. I am going to, we talk about, and I'm realizing now all of my cases are sort of female oriented, but we, are trying to move towards talking about birthing people and being sort of not as specifically gendered. But I also wanted to say a disclaimer that a lot of the research and work that's done in this area does refer to birthing people as women or moms. And so you will hear a lot of that, but we're going to try to sort of be a little bit more gender inclusive in our language today. So Nora is a 4-month-old female who's brought in by her mom for a routine well child visit. She's the 3rd child in her family. The mom, her name is Kelly, is at home with her children while her partner works outside the home. She routinely brings in all of her children to your visits, but you've never seen the mom as a patient. Nora's birth was complicated by a difficult repeat C-section and a short NICU stay for some difficulty breathing after birth, and she lost a lot of weight after delivery due to some difficulty with feeding, which is now resolved. Baby Nora is exclusively breastfed. And normally when you meet with Kelly and her family, Kelly's pretty bright and calm, but today she just seems more tired and less engaged with her kids during your visit. These cases may be a little bit like medical provider centric, but I think a lot of us who are working in different fields could probably see how we insert ourselves or change some of the details to feel like it's a little more applicable. Um, when you mention this to Kelly, she reports that she's been more irritable and easily sensory overloaded lately. Her baby only wakes up 1 to 2 times a night, but her 2-year-old often gets up frequently. And Kelly does most of the overnight care because her partner has to be up early for work and he operates heavy equipment and needs to really be alert and not fatigued for that. In addition to the overnight things, Nora tends to be fussy in the early evenings. When Kelly is talking about her birth experience, she says she starts to have feelings of racing heart and feeling flushed. And also that recently she's been feeling like food is getting stuck when she swallows, and that also precipitates this feeling of her heart racing and feeling flushed. It's evolved into her feeling pretty nervous at meal times and worrying that she's going to choke while she's at home with her children. And sometimes she skips eating because of it. This is based off of a couple of real patients of mine that have kind of amalgamated into one. So I like starting with this because I think it highlights a lot of different things that we're going to sort of talk about throughout the rest of this presentation as far as peripartum mood and anxiety disorders. So PMADS is the #1 postpartum complication. It affects about 1 million women, self-reported, and that equates to about 1 in 5 people who are birthing and 1 in 10 birth partners. Can present anywhere during pregnancy or in the first year of life, though some research is showing that could present even up to 2 or maybe beyond that, especially around the time of stopping lactating is a time where people may have a similar onset or experience with PMADS. It's likely to recur in future pregnancies. So if you had it in one pregnancy, it's likely to happen again. And it is the most underdiagnosed obstetrics complication. Only about 40% of cases are detected. In Montana specifically, 1 in 6 women report having depression during their pregnancy. So our rate is similar to that of the national average. So we know it's the #1 complication related to childbirth, but how is it different than when we're talking about sort of garden variety anxiety or depression? Like, why do we want to spend all this time talking about this topic in particular? Because the things that are happening in the setting of someone's life at the time they're experiencing a peripartum mood or anxiety disorder is really different than any other time in their life. And that causes it to present and to look really different. So there are hormone changes related to pregnancy that can alter mood. So as we're getting close to the timing of delivery, hormones like progesterone and estrogen are increasing. And with that, that increases cortisol, which is our stress hormone. So thinking about a time where we've been stressed out and we have that really sort of fight or flight response, that's naturally what's happening as we get closer to delivering, which is good because we need to have all of that sort of adrenaline for the marathon that is childbirth, but it can increase our risk of having some mood or anxiety changes. In the postpartum period, so after you've delivered, we have a sudden drop in that progesterone and we have decreased sleep now that we're caring for a new baby. And those things together can alter sort of our hormonal milieu that affects our mood. And then also in the postpartum period, the parts of our brain that are receiving these hormone messages change. And so they're less responsive to the messages. So serotonin is sort of the hormone that makes us feel good or feel happy. And it's less active in our brain after birth. There's lots of, besides the hormone changes that are putting us at risk for mood and anxiety disorders, there's social and emotional contributors. Social media plays a really big role in this, the sort of good mom versus bad mom paradigm that I think a lot of people who are parents or have birthed children experience, right? There's a lot of messaging on like what you should do to be a good mom, what you are doing that are making you a bad mom. And it's pretty pervasive, and that just puts people at increased or heightened risk to experience mood or anxiety disorders. This is happening at a time we're having adjustment to new roles and new responsibilities, especially for first-time parents, but even for parents of subsequent children. Our life is very different, and how we're navigating through it is completely different. And in our modern society, we have pretty limited support systems. We have loss of that village that helps people and families be successful, especially post-COVID. And then there's some things that some people may bring into their pregnancy and postpartum experience that might put them at higher risk, like perfectionism or need for control, if that's a baseline personality trait, like it is, let's say, amongst many medical providers. People who have high worry or low self-confidence may be at slightly higher risk. And people who may experience some body image dissatisfaction may be at higher risk. And the pregnancy and postpartum period is definitely a big amplifier of body image dissatisfaction for lots and lots of people. So that's why it's different than other types of anxiety or depression. But why do we care so much about it? We care because it has pretty widespread impacts on the pregnancy experience, on the parenting experience, on child health outcomes. There's also a huge financial impact. It is estimated that untreated PMADs have multi-generational consequences, costing our state $42 million annually. Beyond the money, so in pregnancy, high levels of cortisol, that stress hormone, may lead to lower birth weight babies, maybe leads to babies who are born early, and increases the risk that someone who's pregnant may have a hypertensive disorder like preeclampsia in their pregnancy, which is a medical complication of pregnancy that can be really severe and dangerous. It can impact parents by increased stress can also cause stress on the parental relationship. There's an increased risk of interpersonal violence during pregnancy at baseline, and mood and anxiety disorders can also increase the risk of domestic violence or interpersonal violence in a relationship. And there's a risk of suicide for one or both parents. Impacts on child health. There are things as simple as a heightened neonatal startle reflex. So all babies have a little bit of a startle reflex when they're born, and that can be heightened in the setting of an anxiety disorder or a depressive disorder. Children born to parents who are experiencing untreated PMADs can have an impaired social interaction and delays in development. It can also contribute to mood and behavioral disorders in children as they become older, and increases the risk of infanticide. Impacts to the parenting experience, in addition to just impacts on the parent themselves, can lead to impaired attachment or bonding between a parent and their infant. We have lots of data that shows peripartum mood and anxiety disorders are associated with early cessation of breastfeeding, impaired parenting skills, including a failure to implement preventive safety measures, increased incidence of abuse or neglect in families, and parents who have uncontrolled mood and anxiety disorders may have a harder time managing not only their own chronic diseases, but those of their children if they have a child who has chronic disease. So that's why we care. What does PMADs look like in reality? PMADs, if we can distill it down to one thing, which is very simplistic, is distressing feelings during the pregnancy or postpartum period. If we can distill it down to one thing. Historically, we really emphasized depressive symptoms. You hear a lot about postpartum depression, or people say, I had postpartum. Usually they're referring to depression. I think a lot of pop culture popularization of postpartum depression, which is not a bad thing. That's a good thing. But what that leaves out is a pretty significant contribution of anxiety presentations in the perinatal period. And so really, when we're talking about mood in the pregnancy and postpartum period, we should be talking about anxiety and depression, which is this term, peripartums, which means either while pregnant or in the postpartum period, mood referring to depression, anxiety disorders and referring to anxiety. Sometimes people can classically present as just depression or just anxiety, but the symptoms may also be mixed. And depending on someone's underlying mental health diagnoses that they bring into pregnancy in the postpartum period, that may look really different. We're going to focus a lot of our conversation on anxiety symptoms today because I think they get less attention, and because frankly, anxiety symptoms are probably more common. And they tend to present in a more high functioning way, meaning that people may outwardly exhibit less distress, or they may be able to go about their day-to-day more while still having these symptoms and suffering, which means that it's harder to recognize these patients. And we, just by looking at people, may not be able to pick these up as well. Anxiety can look a lot of different ways, and we'll talk more specifically about all of these. It can be generalized anxiety, it can be panic, it can look like PTSD or OCD. It can even just be presenting as insomnia, which can be a sign of anxiety. And in extreme cases, peripartum mood changes can manifest as suicidality or psychosis, and we will talk a little bit about that more in a second. So, depression, specifically when we're talking about postpartum depression, can look lots of different ways. Sort of our most classic symptoms of depression that we think about in all people, not just peripartum people, are persistent feelings of sadness or emptiness, loss of interest or pleasure in things, or a feeling of hopelessness or pessimism. Specifically in peripartum patients, it may look a little bit more like irritability, frustration, or restlessness. Guilt, worthlessness, or helplessness. Rage can be a presentation of postpartum depression. Some people may say that they have feelings of persistent doubts about their ability to care for their baby, or trouble bonding or forming emotional attachments. And there are other ways that can present too, that again, maybe are less pregnancy or postpartum specific, but inability to make decisions or concentrate, having difficulty sleeping. And I caveat that by even when the baby's sleeping, because most people who are in the postpartum period have difficulty sleeping because they have a baby.
Mm.
Excessive crying, fatigue, again, that is out of proportion to how much sleep they're getting. Mood swings, appetite changes, physical aches or pains like headaches, cramps, or stomach sort of discomforts. And in its extreme state, thoughts of death or harming oneself or one's baby. Anxiety can also present really similarly. Someone heard a mic pop up. No? Okay. Anxiety can look similar. Common anxiety symptoms can be intolerance of uncertainty. So difficulty with, I think that way that it may practically manifest for some people is sort of the uncertainty of like, I don't know how much my baby is getting when I'm breastfeeding, because I don't know the exact amount. I know how long I'm breastfeeding, but I don't know how much they're getting. And a lot of distress about that, or distress about, is this normal? Is this not normal? Is a pretty common way that it can present. Being hyper alert or having excessive behaviors to prevent undesired outcomes. So hyper alertness in the postpartum period can present as excessive checking on your baby to make sure they're breathing, or doing lots of excessive behaviors in a thought that it's going to prevent an outcome, like, let's say, SIDS. Poor problem orientation or low self-esteem and self-efficacy, so difficulty with problem solving or feeling like the things you're doing aren't enough. Some people may have avoidance of things that are causing them distress, and that could result in sort of avoidance of spending time with their baby. Some people may experience panic, and then again, the excessive checking and tracking is also a pretty common manifestation. We'll talk a little bit about that. Specifically, people who are presenting more with post-traumatic stress disorder type symptoms, oftentimes that's triggered by pregnancy or a birth experience. It may also be that the pregnancy or birth experience harkens back to a prior traumatic event too. And patients oftentimes report having symptoms like reliving a traumatic event, such as flashbacks, nightmares, sense of doom, hypervigilance, or increased arousal. Perinatal OCD, which is a really specific presentation that is can occur for people who do not have OCD at baseline or outside of the perinatal period. And this is something that I actually see quite commonly in the postpartum period. I'd say this is maybe one of the more common presentations that I see in my practice, is intrusive or repetitive thoughts, which are usually upsetting. We'll talk about why I say they're usually upsetting in a little bit. So an intrusive thought might be, my baby is in the bouncer in the kitchen and I'm preparing dinner and I am chopping vegetables. What if this knife flies out of my hand and hits my baby, right? This person's not saying they're going to stab their baby, but like this, like now I cannot stop thinking about what would happen in this extreme instance where something like that happened. And then perinatal OCD usually has some sort of compulsions or repetitive behaviors to sort of, again, prevent that outcome from happening. Breastfeeding can also be a big trigger for anxiety symptoms, or a big focus of anxiety symptoms. Again, a little bit of that maybe is like that uncertainty aspect, like, am I making enough milk? Am I breastfeeding right? Am I breastfeeding long enough? Is my baby getting enough? Am I pumping enough? Can be a big sort of focus or trigger for people who are experiencing anxiety in the peripartum period.
Dr. Greenberg,
Yeah.
we had one question or we had a couple questions in the chat, but it was, and you hit one with, or you answered one in your last slide, but wondering about prevalence of anxiety in the peripartum, right? You mentioned the 1 in 6 and the 1 in 5 and 10 statistics for the different parts of the population, but really knowing that's depression. So Devery was wondering about prevalence of anxiety specifically.
Yeah. We don't actually know the answer to that question because it's likely underreported and underdiagnosed. We think it's potentially as high as twice that of depression. Um, I've seen different numbers like 40%, 60% thrown out, but no one really knows. If you look at some data, they say it's less prevalent than depression. But again, that's probably because we're not actually studying or looking for it. So it depends on which resource that you look at.
Awesome. Thank you.
Yeah, of course. Yeah, it is really high. And again, having anxiety symptoms and having an anxiety disorder may not be one and the same, right? But if we go back to that feelings of distress sort of definition, we're probably in the realm of pretty high. If they really knew how I was feeling, they would think I'm a bad mom. Am I going crazy? Why is everything so hard? Everyone else seems to be so much more put together. What if I drop the baby or they stop breathing? I thought this was supposed to be such a joyful time. I can't connect with my baby and I'm so miserable. I don't even want to leave my house. I don't want people to see what a failure I am. Sometimes I just want to scream and run away. My baby would be better off with a different mom. I like having these quotes or these sort of feelings because we can talk about, practically speaking, it might look like this, it might look like that. And this might actually be the way that someone's expressing to you how they're feeling, or afraid to say the things that they're feeling inside. And these are some really common things that you will hear people say, or express sort of as a way to talk about their mood or anxiety disorders. So let's go back to Kelly, who reported she'd been more irritable and sensory overloaded, two of which can be signs of peripartum anxiety. Her baby's fussy, and we'll talk a little bit about risk factors in a second, but having a more difficult or fussy baby can increase our propensity for having an anxiety or disorder or depression. She reports having the sensation of feeling like her heart is racing and she's feeling flushed, which are panic symptoms or can be PTSD related symptoms of, especially when she's talking about her birth experience, right? Harkening back to some of those post-traumatic stress symptoms. She has a sensation of food getting stuck. And I have not seen this specifically called out when I'm looking at sort of literature talking about anxiety disorders, but actually this is how two patients of mine presented sort of in short back-to-back sequence, that this was a sensation that they were having. And it was causing them to feel nervous and worrying that they're going to choke, and sometimes resulting in not eating, avoiding that behavior that causes that symptom. So what do we think Kelly is experiencing? Put it in the chat. she fine? We're just gonna be like, no big deal, girl, you got this. She's experiencing pretty classic symptoms of peripartum anxiety at the very least, right? We haven't delved more into depressive symptoms, right? But reading this makes me anxious, right? So our second case, Mira, is a 27-year-old. She has 3 children. She's 9 months postpartum. And she is coming in with several months of headache, weight loss, and just feeling really run down and fatigued. She says she has trouble falling asleep and is often up multiple times a night with her children. And then she has trouble falling back asleep. She's only getting about 4 to 5 hours of sleep a night. Her headaches are worse on days when she is not sleeping well, and she does report that she sometimes her neck hurts, and that is associated with her headaches being worse. She oftentimes prepares multiple meals a day for her children, but is too busy to eat herself, and so oftentimes skips meals throughout the day. Not because she's afraid to eat, like our last patient, if she's nervous, she doesn't have time for it. She doesn't have a working car, and she lives pretty far out of town and rarely has visitors and doesn't get to spend a lot of time outside the home. This sounds pretty similar to some people that we're interacting with, some of our clients. Her partner's not home a lot because he's away for work. At your clinic or wherever you're practicing or working, you are just screening for depression. And on the PHQ-9, which we'll talk about a little bit more later, she circles several days on thoughts to feeling like she'd be better off dead or self-harm. What do we think Mira is experiencing? Yeah, depression. So remember when we were talking about ways that depression or anxiety can present? Sometimes people will have what we call in medicine somatic symptoms, but physical symptoms that are symptoms we're feeling in our body that are related to sort of the state of our mental health. She's having headaches, she's having weight loss, she's having fatigue. So let's talk a little bit about our crisis presentations, because we see a lot of anxiety and depression. We don't see a lot of suicide, but it's the second leading cause of maternal death in our country. Birthing parents with a history of depression have a 70% greater risk of suicide, and 14% of birthing parents report suicidal ideation at some point in the postpartum period. And so we don't see it a lot, but we should definitely be hypervigilant and are looking for it. The other crisis presentation of PMADS is psychosis, which is very rare, but is always an emergency. It only occurs in about 0.1 to 0.2% of births. Patients who have a history of bipolar disorder are at a higher risk of having psychosis, but bipolar disorder, which is a mood disorder in and of itself, separate from depression, separate from anxiety, the first onset of symptoms in women identified people is usually in your 20s, mid to late 20s, which is also the time that many people are experiencing their first childbirth and first pregnancy. And so many people may not have a diagnosis of bipolar disorder, even though that actually is their underlying condition. And the first thing we might see might actually be their presentation of postpartum psychosis. Usually it looks like agitation, thought disorder, or going on birth control. Yeah, for sure. That can be a trigger as well. Hallucinations, either visual or hearing, auditory hallucinations, delusions, feeling paranoid, feeling really disassociated from reality. And psychosis is associated with increased risk of infanticide and with suicide. Whenever you hear about cases in the news of parents killing their babies or mothers killing their babies, at the heart of it, it is almost always actually a presentation of postpartum psychosis. And there are people who are experts in this and do this sort of as a forensic psychology. And almost all of those cases can be linked back to this, to untreated mood or anxiety disorder and psychosis. That being said, I think it is really important to understand the difference between psychosis and not psychosis so that when we see it, we know it because we know it's an emergency. And regardless of sort of the realm of which you are working and interacting with people who are postpartum or pregnant, if you see real psychosis, like that is referral to the emergency room, that is calling 911, do not step past go, do not collect $200. But there's lots of things that can look odd or really concerning that are not actually the same thing as psychosis. So I think it's worth just talking a little bit about that for a second. True psychosis, like I said, is rare. How long is the possible window for a birthing parent to experience psychosis after birth? Usually it's within the first several weeks after birth. It's most commonly within the first, like, say, 2-ish months. It can happen past that, but most commonly it's going to be in that really immediate postpartum period related to sort of those really significant hormonal changes, but it can happen further than that. So true psychosis is rare and is always an emergency. Like I said, usually associated with either or both auditory or visual hallucinations. And those hallucinations are bizarre and are non-distressing to the parent, right? I am talking to God, and God says that my baby, if I drown my baby, they would become an angel and they'd live forever. And I want that for my baby. That would be great. They should totally be an angel and live forever, right? I mean, I'm being very like simplistic maybe. But like that this that makes sense to me. As opposed to like a symptom of like, gosh, that's a horrible, I'm having this sensation and I'm scared about the way that I'm feeling. People who are having true psychosis are non-distressed by their symptoms. It can, like I said, be a standalone symptom. We just have psychosis and that's it. But it can also happen in the setting of either severe anxiety or depression. We call it anxiety or depression with psychotic features, sort of in its DSM criteria. So it can be standalone, it can be in the setting of some of these other symptoms. OCD, I had mentioned, can have these intrusive or ruminating thoughts and can be confused by people. Yet spiritual psychosis is a pretty common presentation in the chat I see of psychosis, but it can be related to a lot of other things. Spiritual tends to be a pretty common presentation. People with OCD have intrusive or ruminating thoughts, which is different than psychosis, because usually those intrusive or ruminating thoughts are distressing to the parent, right? This thought that I may accidentally stab my baby because my knife is going to go flying across the room. Like, I'm scared of that. I'm distressed by that feeling. I don't want that to happen. And so I have seen people say like, oh, this person is having intrusive thoughts, that is psychosis, or having auditory hallucinations, that's psychosis. But when we get down to the nitty-gritty of it, the way that they are responding to these symptoms is different. And so then it's probably not psychosis. And important, but maybe not an emergency. People can also have intrusive thoughts without OCD. You can just have intrusive thoughts in the postpartum period, and we'll talk about that. And then remember that lack of sleep in anyone, a pregnant person, a postpartum person, someone not in that realm, can result in some amount of visual or auditory hallucinations. And that is unrelated to mood. I've never seen this movie. My husband always says this movie. There's some Patrick Swayze movie called, I think, like Black Dog or something, where he's a truck driver and he doesn't sleep and he starts having hallucinations while he's driving. So remember that. Patrick Swayze. Okay. Who's at risk for experiencing anxiety for PMEDs? People with an increased risks are people that tend to have more life stressors or more limited support. People with a lower socioeconomic status, teen parents, people with a history of trauma, having had their own experiences of adverse childhood events. People who have partnership strain during their pregnancy or postpartum period, people who are single parents, military families, often because of family separation, LGBTQ identifying parents, because our system and our world is not set up to support them well. BIPOC patients or immigrant parents may also have increased risk of stress. And specifically thinking about our population here in Montana, up to 30% of people who are American Indian Alaskan Native experience PMADS, which is higher than the baseline prevalence. People who have a history of a mood or anxiety disorder before pregnancy, either their own history or family history, are at increased risk. Also, people who have a history of substance use disorder, even if it's in remission. People who had mixed feelings about their parenthood or have poor relationships with their own parents, specifically poor relationships with their own mothers, are at increased risk. People who have PMDD or PMS, like other hormonally caused or mediated mood changes, are more likelihood to have also worsening symptoms. And people who have pregnancy complications, like they had a premature delivery, they experienced birth trauma, their baby was in the NICU, or they were separated from their baby in the first days of life for some reason. People who had fertility issues and underwent IVF or other fertility measures, and people whose children had childhood illnesses, like had emergency room visits or hospitalizations, are at increased risk. And regardless of any risk factors, even if you have no risk factors, anyone can develop a PMADS. And remember, non-birthing parents can experience it too. About 10% of fathers will experience a mood disorder, especially if the mother also has one. See a question about excessive copper and PMADS and the postpartum psychosis. There is a very rare condition called Wilson's disease, which is a inability to process copper that is associated with psychosis. It's sort of like, I feel like there was someone in European, like royalty who experienced that or something. That's like a classic person. We can't think of who it is, but that's a rare thing. There probably are some nutritional imbalances that can worsen mood. I don't know specifically about copper itself, but definitely nutritional deficiencies or imbalances of any kind probably could worsen the presentation of symptoms. Yeah. So we're moving on to our third patient, which we're doing, I think, okay time-wise. Kayla is a 38-year-old patient who has been pregnant 3 times and has 1 baby. She had 2 miscarriages. You're seeing her at about 6 weeks postpartum. She used IVF to become pregnant, and her delivery was uncomplicated. She reports that she is doing really well. She started back at yoga 3 times a week. Her baby's doing great, breastfeeding every 2 to 3 hours during the day and every 3 to 4 hours at night. Though mom says her baby falls asleep pretty quickly after feeding at night, she sometimes is up for at least an hour researching baby sleep solutions, normal development, or buying things for the baby online. She reports sometimes she doesn't even go to sleep between feeds, so she's up a lot of the night. She appears well-groomed, she's cheerful, but her partner is with you and also expresses that he is concerned because sometimes she's pretty tearful at home and maybe spends a lot of time tracking diapers and feeds using an app on her phone. What do we think is going on with Kayla? Yeah, anxiety. Could this be normal? Could be normal. Yeah. All right, let's talk about the difference between normal and maybe not so normal. Isn't it just the baby blues? Everything's fine. You just had a baby. It's normal to feel this way. It's just because you're not sleeping. But you look so great. You must be fine. Who has heard this about themselves in any context? Yeah, I'm sure many of us have heard that. So I hate the phrase just the baby blues. I kind of even hate the phrase baby blues because I think it sounds cute, right? It's like this cute thing that's fine. And I think it kind of undercuts the way people are feeling, or minimizes. It is normal. Many parents, I would argue to say most parents, feel overwhelmed and depleted at some point in their pregnancy and postpartum journey. And in fact, 90% of birthing parents experience scary or intrusive thoughts about themselves or their babies. Remember, we said OCD can be intrusive thoughts, especially if we're having these behaviors to compensate for them. But even people who don't have OCD may have intrusive thoughts, right? An intrusive thought is, what if my baby stops breathing and dies? Like, that's a normal thing to think about, right? But if it becomes too pervasive or we can't stop thinking about it, that's not normal, right? But it's normal for us to have some of these intrusive thoughts. They're good. We should be worried about car seat safety for our kids and making sure they're buckled in because we want them to be safe, right? But there's a line that crosses where it stops being helpful, right? Symptoms of PMADs overlap with normal postpartum adjustment. And so it can be really hard to figure out who has PMADs and who is just normally living their lives as a postpartum experience. The difference is that baby blues is self-limited, should only last for the first few weeks. But having had baby blues will increase your risk of developing a PMADS. So 15 to 20% of people who have baby blues will go on to develop like a true PMADS. And a way that you can help differentiate it is that patients who are beyond 2 to 3 weeks postpartum and are still feeling sad, weepy, anxious, nervous, or worried about the way they're feeling. I want you to put that in your brain. Worried about the way that they are feeling. It's no longer just the baby blues. And if someone, regardless of how long it is worried about the way that they are feeling, that is someone we should pay attention to. That's someone who deserves our attention. Okay. So again, how do we differentiate between baby blues or normal postpartum adjustment and what is a PMADS? It's based on, and this is how we sort of diagnose any mental health disorder of any kind. It's based on these tenets: frequency. So how often is it happening? How intense is the feeling? How long is it lasting for? How much is it distressing the person? And is it interfering with their everyday life? Right? So if the answer to all of these things is low or not really, maybe it is normal postpartum adjustment or baby blues. And if the answer is higher to these things, it's lasting longer, it is more intense, it's causing distress, then maybe it actually is passing over that threshold. So thinking about Kayla, she's a risk factor for PMADs in that she had IVF, right? So we had said people with fertility struggles are at increased risk. She's engaging in some behaviors that could be related to anxiety, doing some excessive checking, doing excessive researching, not sleeping. So maybe she's tearful, maybe. She maybe is consumed by tracking. The other thing that's highlighted on here is at 6 months postpartum or 6 weeks postpartum, going to yoga 3 times a week seems like a great achievement, but also maybe is like a little bit much. Yeah. Like a lot of people 6 weeks postpartum would not have the energy or sort of ability to do that. And so like, is this actually like a compensatory mechanism or like we're working extra hard to feel better? So maybe this patient does, maybe she doesn't. You would need more information, but these are all things that should be sort of your spidey sense. Yeah, it would be important to know what her baseline is. Yeah, if this is someone who was doing yoga 3 times a week prior to pregnancy up until the day she delivered and is back at it, yeah, this could be totally her baseline, and this is just how she lives her life, and that's great. And if it's not, then, oh, it wind into self-care. I love it. This is our last case. Hannah is a 19-year-old. She has been pregnant twice, and she is currently 32 weeks pregnant. She doesn't have any babies. She has been to labor and delivery many times during her 32 weeks of pregnancy for things like belly pain, urinary symptoms related to maybe urinary tract infection, concern about decreased baby movement. She had hyperemesis, which is a condition where people are unable to keep food or nutrition down and are vomiting excessively and have excessive weight loss or dehydration early in her pregnancy, and she was admitted to the hospital twice because of it. In early pregnancy, she was using marijuana and she was smoking cigarettes, so she had stopped. And she oftentimes is calling after hours to the on-call line at whatever office she's at, or going into labor and delivery for lots of symptoms. You look at her medical history, and she has a history of sexual trauma and a distant history for inpatient psych hospitalizations. What do we think is going on with Hannah? She's good, she's fine. We're not worried about her. We're a little bit worried about her. We need more information. Yeah, I'm worried about Hannah too. She could have a UTI. All of this could totally be real blue medical stuff for sure. Yeah, it could, maybe is there a reemergence of some of her PTSD history and trauma for sure. Pregnancy, even not having had a birth experience yet, pregnancy can trigger PTSD like symptoms related to sexual trauma for sure. So she has a bunch of risk factors, having had a history of trauma and having had a history of a mood disorder requiring a psych hospitalization are risk factors. And she has maybe some somatic symptoms, maybe some real medical stuff, maybe some excessive worrying. So, what are some warning signs that someone may be experiencing mood disorder, right? Because patients might come up to you and say, I think that I'm experiencing a PMADS, but they're probably not. So, how are some things that we should look out for that get our little spidey sense up and say, like, ooh, I should think about this patient a little bit more? Because I think we've had our spidey sense up for a lot of these patients, right? Is paranoia a term we're using at all? Paranoia in the setting of psychosis, yes. I would say like excessive worry for someone who is not psychotic or having psychotic symptoms maybe is like a differentiation because paranoia is like above and beyond what seems reasonable. Whereas excessive worrying, like, yeah, your baby could have died, right? You could have had a stillbirth or a intrauterine fetal death if you're not feeling your baby move, or you could have a urinary tract infection. Like that's reality based. That is not untrue, even if it's maybe not true in this moment. Whereas paranoia is like, that's probably not like reality that it could happen, is like the way that I would define it in my head. But good question. So parents or pregnant people may present as having missed appointments, or the flip side, overutilization of the ER or sick visits or like the on-call service. Yeah, you definitely want to know, Devery, if how her symptoms are impacting her. Because she's like, I'm experiencing these things and they're not bothering me, or I'm not distressed by them. Right. That is a totally good point. People who are excessively worried about their babies, on the flip side, like excessive attention or worry is one way that it might present, but you may see people who just like are really blunted and really pulled back. We call reduced attunement. So their affect is blunted, like we've all talked to those people who are just like, what's going on? Like you just seem like kind of flat. Maybe less eye contact, though knowing that that may be culturally normal for some people too. Not as responsive to their children's needs. So baby is crying and we're not even paying attention to it. Maybe that's because we're doing cry it out, or like this has been going on all day and we've addressed the problems. We know there's nothing wrong. This baby just needs to cry, but maybe not. And then people who are tearful or irritable may also that be a sign. Babies or children who are coming in that you should be concerned maybe that the parent is experiencing PMADS. Sometimes babies that are irritable or fussy or difficult to soothe. It's a little bit of a catch-22 or like chicken egg scenario, which is like, is your baby irritable or fussy and therefore that causes an increased risk of PMADS? Or is the baby irritable or fussy because there's reduced attunement because the parent has depression or anxiety and they're not tending to baby needs? Poor eating or sleeping, again, chicken and the egg a little bit. Poor eye contact or engagement from the baby or the child, resistant behavior in an older child, or restricted growth and development, like babies who have failure to thrive or are not growing appropriately. Mood disorders should be on our differential for those babies. So again, looking back at Hannah, we said that she had some risk factors, substance use and smoking also being one of them. Hyperemesis is a medical condition, but we see it happen more commonly in people with a history of trauma or a history of mental health. We don't totally know why. Was there a question? Or just surprised that those things are related?
Yeah, that's just that's so interesting to note that there's, like that correlation is there, but figuring out the causation piece of it, that's fascinating.
It's hard to know what's the cause, right? Like if you were throwing up a lot and unable to maintain your nutrition, you may feel anxiety or depressed because of it, but people who at baseline have it also are more high risk of it.
Yeah.
So so we know how it looks. How do we diagnose it? How do we say people have a PMADS or get them into treatment? And we know diagnosis and treatment is important. One study showed that 16% of women were depressed at 2 to 4 months postpartum, and 15% of those people were still depressed at 30 to 33 months. So just white knuckling it and hoping it's going to go away is not going to work great for a lot of patients. And thanks to HMHB for these beautiful graphics. So we suspect someone has something. We suspected Hannah had it. We suspected all of our other patients in the presentation had it, but how do we actually say you do? How do we diagnose it? So we should, in addition to just being like, ooh, our spidey sense is up about someone, we should screen everyone, which means that we should look, because remember we said some people are increased risk, but anyone it could happen to. We should screen anyone regardless of risk factors during pregnancy and during the postpartum period. We should be, when we're seeing people while they're pregnant or even postpartum, if it's the first time we're meeting them, ask about if they have a history of anxiety or mood disorder. We should ask about risk factors, including history or current interpersonal violence, substance use, or trauma, because we know those things can increase our risk. And then we should use some sort of routine screening tool. And the American College of Obstetrics and Gynecology says that we should do it once a trimester. So 2 to 3 times during pregnancy, probably. We could do it more, but we should at least do it those many times. And then when we're seeing people who are postpartum, we should also think about using the same evidence-based screening tools, potentially before hospital discharge, though the utility of that at the immediate hospital discharge can be mixed, right? Lots of things are going on. We should definitely do it when we're seeing people in the postpartum period. And my soapbox, again, if you take home anything, is like we should be doing this for parents when we're seeing their children. So if you care for people, for kids, or you're interacting with kids, you're a therapist, you're an occupational therapist, you're a PT, you're interacting with kids, we should be looking for it then. And I will finish my soapbox in a second. So we're talking about screening tools. Why should we use a screening tool? Because just looking and talking to someone or asking questions might get you there, right? But it might not. And the sensitivity, so the likelihood that you're going to pick up that someone has a mood or anxiety disorder just by asking the questions is lower than a screener. We're doing a not great job at screening people. Only about 20% of patients are screened appropriately. And there's a couple of different options on how we can screen people. We can use the PHQ-2 or the PHQ-9. The PHQ-2 is just a short version of the PHQ-9, which is this bottom sort of blue questionnaire. Or we can use the Edinburgh, which is a pregnancy-specific, postpartum-specific questionnaire. In studies, they both are found to be equivalent to pick up depressive symptoms. So it doesn't matter which one you use, we should be using something and build it into sort of our routine thing that we're doing when we're seeing patients or clients or whomever it is that we're interacting with. There actually is not a best option for anxiety. We can use the Edinburgh. A couple of the questions specifically are looking at anxiety. The GAD-7, which is an anxiety-specific questionnaire, can also be used. One is not necessarily better than the other, but none of them show great efficacy in picking up anxiety in the postpartum period or pregnancy period, which again is why we probably have less data, but we should probably be doing something if we know anxiety is a pretty prevalent symptom. And if you work in a medical practice, you can bill for it. So we should definitely do it. In my practice, we use the PHQ-9. I work at a federally qualified health center. We have to screen all patients at every visit for a mood or anxiety disorder. And so we do it on everyone at baseline. And so this is just the easiest. And everyone gets it every time they come in for a pregnancy or postpartum visit at our practice. But that's not necessarily the routine lots of other places. And that's okay. I don't think you need to screen everyone every time. And I'm going to talk a little bit about the pros and cons of screening, but my soapbox for well child care is it's recommended by all the organizations that sort of tell us what is good practice for pediatrics, the American Academy of Pediatrics and Bright Futures. And we should do it because, again, I think we have driven this home. Maternal depression is the leading causes of adverse childhood events under 5. We know untreated mood disorder in a parent has adverse consequences on kids. And most people who are postpartum maybe only have 1 visit with their provider at 6 weeks. Maybe if they're lucky, they have 2. They have a 2-week and a 6-week. Most people, like 40% of patients, don't show up for any postpartum visits nationwide. So they may never be being screened because they may be never seen postpartum. But kids are seen by their pediatric providers a lot more frequently. It's usually the very first visit they're having to a doctor after they've been discharged from the hospital. And it's the most frequent visit, and it's the most longitudinal thing for lots of people. Like, they may not be seeing their own care provider, but they're going to be seeing their kid's provider over and over and over again for their entire kid's life, and they're going to build a relationship and a rapport with this person. And we do it already in regular primary care, and even pediatric offices are screening their teens for anxiety or depression, so it is easier to pull it in. There's no perfect suggestion on how frequently. The American Academy of Pediatrics says, like, we should do it at 0 to 4 and 6 months or something like that. But we also know that there's an increased risk of missed visits in people who are experiencing anxiety or depression. So in my ideal world, I would say we do it every time we see someone because we never know when we're going to capture them or when we saw them last. So that's my little soapbox. And I want to drive home that screening does not equal detection, does not equal treatment. Just because you screen someone doesn't mean that you are that they actually have something. And just because you diagnose something doesn't mean you actually are getting treatment or they're getting better. So this is a tool. It is a tool that is imperfect, but it is a tool and we should probably be using it. Know that just because someone screens positively, again, that doesn't mean that they have the thing. It means we should do more investigation. And just because someone screens negative doesn't mean they don't have it either, right? They may have none of those symptoms, but lots of other symptoms. People with lived experience often report when they have gotten screeners, they have ignored completing them or completed them untruthfully because they're not sure what the purpose of it is, or they're scared about what would happen if they were truthful. And so that's something we really need to consider, is like how we are couching this and how we're explaining it when we're giving to people. People have also said, like, I completed the screener and it was never addressed. It was right there. No one ever talked to me about it. So why is it, like, it didn't seem like it was that important. It was just another box to check. And people have said when they've brought up concerns, they feel minimized when they're bringing up concerns. And so these are all things we have to consider, which is why screening in and of itself does not replace talking to a patient, does not, right? We need to do all of the things. The flip side is providers say they're not sure what to do when they get a positive screener. So maybe they're not going to bother screening because they don't know what to do, or they feel like they don't have enough resources to give a patient. So, like, why should I ask you if you're depressed if I can't do anything about it? I can't get you into a counselor. I don't know where to send you. I would argue knowing is better than not knowing always, especially if all we can do is avoid the really bad outcomes, right? Like, even if you had no other resources, knowing that someone has such severe depression that they're feeling suicidal, like, is an important thing we can action on, even if you had no other resources. And I would say we probably are never in a position where there are no other resources. And some people feel like it's just outside of their scope and they're not sure what to do with it, which I also don't think is a good response, but it is something that people may say. Yeah, and there's sometimes talking is the intervention, right? For sure. Normalization and talking and feeling heard and feeling seen is huge. We should not underestimate the power that is that. Ashley, perfect segue. We should normalize, we should reassure, we should have people feel heard. And we should have close follow-up. Even if I know that I can't get you in to see a therapist because you don't have insurance or everyone's a mile out, right? I can see you. The home visiting person, I can make an appointment sooner. We know that we're going to see you, get you again in WIC. Like, we can touch base, right? This doesn't have to be your profession. You're not having to provide a professional intervention, but being there and being seen, we should never underestimate the power in that. Things that we can do that are within our scope, even if we're not a mental health provider, are we can talk about how to promote emotional wellness. How do we promote stability? Is it working on creating a routine? Is it working and incorporating some amount of self-care? I love that we're going to have a talk about real self-care. Is it exercise or movement, which we know produces natural endorphins? Is it talking about sleep and figuring out how we're going to get you more sleep? Is it talking about nutrition? Right? And saying, like, you are frankly not eating enough, or you're not drinking enough, or we're not caring for our body in a way that is sustainable. Like, how can we improve that for you? Is it helping someone connect to their own support system? Right? Who is it in your life that you could call? Can you talk to your mom? Can you talk to your partner? Can you talk to a friend? It's referring to support services within our area, visiting nurses. Like, the more touches that we can get someone, the better. Do you have a postpartum doula program in your area? Can we connect you with lactation support? Can we connect you with WIC? Is childcare the problem, and what resources do we have? Are there parenting groups that maybe have nothing to do with anxiety or depression, but just get you in the room with other people who are having lived experience like you? Mom's group for sure. Get on Facebook. Like, where are these groups that are happening that you can interact with other people? Anyone can help connect someone to a mental health provider or suggest that they see a prescriber, right? That's within the scope of any of us to say, like, hey, this maybe is something that I would recommend, right? And we can help facilitate that. Even as simple as, we're going on Psychology today and we're going to look up and you're going to call these 5 people. And we should be assessing for safety, right? If we do nothing else except for rule out the 2 emergencies, right? At least we've done something. And we can provide crisis and support lines. That's within everyone's scope. This is just some local Montana things that we can refer to, and some nationwide things on the right-hand side. HMHB, lots of great resources. Their LIFTS resource, like, if you're not sure where else to look, I'm looking for a mom's group, or just their postpartum support group or postpartum doula program, like, maybe it's on LIFTS. And if you're not familiar with LIFTS, go to the website. There you go, Stephanie. We have a podcast in our state about motherhood and the difficult journey that it is. Check out Mother Love. Lots of areas have support groups or resource groups within the area. In the Flathead, we have postpartum resource group, which runs support groups, peer support groups for people experiencing mood and anxiety disorders. In our state, we're actually doing a lot of great stuff. The PRISM line is a psychiatric consult line, and this would be something that a provider would have to access. But, like, let's say you live in Cutbank and there is not a psychiatrist or psychiatric provider. It is a consult service that the state pays for. Roots Family Collaborative, I've heard great things about them too. In Gallatin and Park counties, love it. And there's a national maternal mental health hotline that you can connect people to that is different than the 9888, which is the suicide hotline, which definitely we should be utilizing if patients are feeling suicidal, but the maternal mental health hotline is available. And we should be addressing barriers to engaging in care as part of this. Can you not get there because you don't have a car, because you don't have childcare, because of your work schedule? Like, what can we do to try to minimize it? Is it like we could get you connected with WIC because you don't actually have enough money to be able to get formula or other supplies? And, like, that's something we can connect you with to be able to at least relieve that barrier or that stressor. Medicines, I'm not going to belabor it because we're running close to time, but medication is safe and effective. Period. End of story. It doesn't seem like anyone on here is a prescriber, so I don't need to get into the details, but medication is safe and effective. And if patients are experiencing anxiety or depressive symptoms, we should refer them to people who can help get them on medication if that's what's felt appropriate for their care. Refer patients to their OB, refer patients to their PCP, refer them to a psychiatric provider, get them in somewhere. And if a mom's not open to medication, next best option, I would say get them into good counseling, get them into good supports, make sure their nutrition and exercise and sleep and all those other things are optimized. And we know data says the more time we mention something to someone, the more likelihood they're going to follow through. That data is like the data on smoking cessation is the more times your medical provider mentions stopping smoking, even if you don't do anything else besides mention it, they're more likely to eventually quit, right? Like we should talk about it and normalize it. And maybe that's not for everyone. For sure, it's not for everyone, but we should talk about it. We can use almost everything we would use for normal depression or anxiety to treat PMADs. And so most things someone has maybe been on in the past would be safe to try again. We do want to be cautious about not giving people things that are too sedating or that are going to impact overnight arousal or breastfeeding. And there are new things that are short acting that are not like being on an SSRI for months and months that we can use for severe postpartum depression, though they may be harder to access. And that would have to go through a specialized provider. What can we do? We're all here. We're in the next steps, right? We are doing the next steps, which I love. We can improve provider, patient, community, I should have on there, knowledge about PMADs, right? The more we know and the more we talk about it, the more we can pick up when people are in distress and help them, and the more we can normalize it, right? We should encourage people in our area, medical providers, non-medical providers, anyone who's interacting with a pregnant or postpartum patient, to get trained or continue their education in peripartum mood and anxiety disorders. There's special training that providers can do through PSI, Postpartum Support International, which I forgot to mention in the last slide. And that is open to people who are nurses, who are doulas, who are community health workers. Anyone can take that. We should increase our screening during pregnancy, in the postpartum period, during well child care, and we should probably screen and identify non-birthing parent partners, which we are just not universally doing at all. Like if we're doing a poor job with it in people who are pregnant and postpartum, we're doing an even worse job in people who are non-birthing. We need to recognize risk and identify patients who are in distress or crisis. If we did nothing else, we should identify patients who are in distress or in crisis, and we should uplift our local resources and provide linkages to care where we can. The Policy Center for Maternal Mental Health talked last year at the conference, and they had this amazing infographic. And so the counties with highest risk, Roosevelt, Lake, Glacier, Bighorn, are not the counties that have the most providers. Missoula, Gallatin, Flathead, Madison, Lincoln. There is a complete mismatch. And so we need to figure that out. Love that, the PSI training. But actually, as a state, we're not doing great, but we're doing better than a lot of other places. So we should be really proud of the work that we're doing here and in other venues. And we know we need to do more. How can we promote some local resources? This is an example of our resource in the Flathead that we just changed our name. The Flathead Valley. Oh, Callie's on here and she's going to flip and kill me. Or I think Callie's on here. We have an organization name and it is escaping me because we just changed it. But we put this together for our local area, and I know a few other counties have theirs, but this is sort of like a paper copy of lists for our area that we can hand to patients. I've used it twice today and yesterday. And it takes a lot of work to update these things, but it is like something tangible that you can give patients, that you can drop off at offices. And if you have a coalition in your area, Flathead Valley Perinatal Mental Health Coalition, there to the very bottom there. It is a lot of work, but I think worth it. So what can we do to mitigate risk? Patients, we should have patient-empowered, trauma-informed, comprehensive care across the spectrum. We should educate our patients. We need to increase our resources and support new parents. And we need to support the whole family, right? We got to do it from the bottom up. How do we lift everyone up? And here are my resources. There is a self-led CBT group from Maternal Mental Health Now, who spoke at, I think, the very first conference, maybe subsequent ones, I don't know, but they have a free self-led CBT for perinatal mental health. If, again, you have no other resources, here are all the hotlines. There are lots of great resources in our state. And then some book suggestions if you want to just read more about yourself, or even Good Moms Have Scary Thoughts is a book that I like tell all of my patients about. I'm like, Karen Kleiman is amazing. And it's a workbook that talks about just like the normal postpartum feelings that people have that maybe delve into anxiety and depression. And I think would be my 10 out of 10 recommend for anyone. References. And I just want to close with, there's no way to be a perfect mother and a million ways to be a good one. From Jill Churchill. So in the last couple of minutes, I want to have time for questions, but specifically, like, is there something that you're doing that is you're like super proud of? Let's hear about it. What do you want to change? And then my contact info is at the bottom if anyone feels like they want to reach out afterwards. And these are my little kiddos last winter here in the Flathead.
Thank you so much, Dr. Greenberg. That was fabulous. I really appreciated the way that you made the distinction between some of the intrusive thought pieces of the puzzle for perinatal OCD and then psychosis as well. And, you know, one of the things when I think about, you know, stories where a mom is reporting intrusive thoughts, and somebody who is, you know, maybe not aware that these are, you know, semi-normal parts of the postpartum experience for many people, that is an automatic alarm bell. And we start to do things like, you know, call Child and Family Services because there's a genuine, you know, concern for the safety of that child and also that mom. Can you talk a little bit about how, maybe the Child and Family Services or Child Protective Services of the piece of the puzzle fits into some of the mental health aspects for moms and parents?
That's a good question.
Big
As a health,
question.
yeah, big question. I think it depends too, like what lens and type of work you're coming at this with, right? Like, so as a healthcare provider, I'm a mandated reporter if I'm concerned about child abuse or neglect, and concern to harm to a child would fall under that. And so, like, if I true blue felt like what someone was telling me was going to result in harm to a child or potential harm to a child, you definitely would have to report that, right? But I don't that's the minority of things that people are saying. Like, if they're saying that, for sure, you should report that, but you should not only just report that, we should make sure that person gets into emergency care. So, like, if you're at the point with a mental health, like, crisis, you're like, I'm so afraid about the imminent risk of this child, I'm gonna call CPS. Like, we should also maybe be thinking, like, I should also be calling 911, because there are potentially 2 people who are at risk here, right? In crisis, I think that's a little bit more cut and dry. In non-crisis, it's a little bit more gray and squicky. And we know that untreated mental health increases risk of child abuse and interpersonal violence, which sometimes is reportable. And if there are children that are involved or in the home, and may be an increased risk of things like neglect or just an unideal environment for a child. But those are usually also not emergencies. Like, some of those may be emergencies, but most of them are probably not emergent or urgent. And so really spending the time to think about and talk, ideally, with a client about, like, I am worried about this, and I think I think that it would be appropriate for me to call Child Protective Services. Like, I think you're probably going to set yourself up for better success in that way. And hopefully maintaining that relationship. Like, if you are home visiting service, let's say, and you're like, I am seeing things that I am really concerned about. If it's an emergency, 100%. If it's non-urgent or emergent, like, I think there's probably time to have some of those conversations and talk about what is safe and what is not safe. And to hopefully say, like, my goal with this is to get you more services. Like, that is, in the end of the day, what hopefully Child Family Services is doing, is linking people to care and helping them access services in a way they might not be able to. it's gray. And I've had this
Yeah.
conversation with our behavioral health therapists and my residents about patients about like, when do you call and when not? And it's definitely, there's a lot of gray. Um,
Yeah.
and I think it's okay. I don't want to say that you should always call if you're concerned, right? Like there's a line, but I think it's okay for it to be gray. Your job is to report, your job is not to investigate. That's their job, is to investigate.
Thank you for honoring that, Greg, because it is a
Yeah,
tough one. And I think that's why I always cut to that, because it comes up.
it does come up. Yeah, for sure. Mood in and of itself shouldn't be a reason to call. Mood that is resulting in a concern for abuse or neglect would be the reason to call, right? Like your inability to care for your child is is at risk of harm.
Thank you.
I have a question.
Yeah.
Dr. Greenberg. So you
Fine.
talked about the screeners and all of that. Can you kind of just like almost like a case study, like play it out for us? Like, how do you talk to your patients about this? Like, I've been hearing so much about oh yeah, well, we hand it to them or we give it to them online and they can fill it out before they get here. Can you explain like what you found in your work to be most effective and just like how you approach it really and kind of almost give us like some starting points to like
Yeah.
talking points to start with?
Yeah, I think there's a difference between what is done in my practice and what would be done in the ideal world. And some of that is just like the constraints of a practice, right? Like I don't run my own practice. I work for a larger practice that has policies, right? What happens in my practice is every patient, every single time they come in, they check in at the front desk and they get paperwork. In that is a PHQ-9 and a GAD-7, which is on a different colored piece of paper. So hopefully then it jumps out as something that is more important. And hopefully that patient fills it out in the waiting room or in the patient room as they're waiting to be seen. And what's supposed to happen is whomever, like the nurse who's rooming them, asks for it and then enters it. And if there's something that's very alarming on it, like the score is high or someone answered any version of yes to the suicidality question, they tell the provider immediately. That's how it works in an ideal, the way that our clinic is ideally supposed to function, though I don't necessarily know that's like the ideal way to provide a screener for peripartum patients. For our patients who are coming in for like well child care, for instance, it's in the packet with the other screeners that we ask people to like talk about their kids' development. Like, is your kid rolling over? Are they able to pick up a Cheerio with their hand? Are they standing? All these other things. It's part of that, which I kind of like because I think it couches it as like these are the normal things we ask people about their child and the family, which I like, but I do see the downside that then people might be like, this is out of left field. What's happening with this? Um, and in the constraint of like, this is how we do it for our practice for everyone, my approach is for specifically pregnant and peripartum patients, if they didn't fill out the screener or I don't have the results, I ask them about their mood and I explain to them why I'm asking and that this is a tool to help us with assessing mental health. And I think people who maybe are hesitant to fill that out feel better once I explain why we're asking it. And then people who have a high result, then I'm talking about what it is and why we were asking. I think in an ideal world, especially if you had more control over your practice, patients would probably get it because there is actually data that says it's more accurate if someone fills it out and is being asked the questions. So they should get it, they should have time to think about it. And then when we see them, we say, as part of all of our patient care, we want to ask about mood. And this is a tool that helps us do that and explain why it's important, why we're asking it. I do think that there's something to be said about the consistency of it too. Like it happens all the time, it happens more than once, and that people get like a little bit more familiar with it. Like it may be that someone's not comfortable answering yes the first time I give it, or the second time or the third time. And as we continue to have conversations and as they continue to see it's just a part of their routine care, it's not being othered or set aside as different, they may eventually become more comfortable. But that's also not the case for everyone. Like someone may always just feel uncomfortable filling it out, which is why we should always pair the questionnaire with the talking, or at the very least asking about mood in addition, right? Like one does not replace the other. They go together, but it's not perfect.
I love it. Yeah. Screening is not the silver bullet. It is but the start of a conversation and building rapport and helping to educate people about, mental health concerns during this time of life.
If we don't,
Right.
we will miss people. If we only ask, we will miss people. If we just give screeners and never ask, we will also miss people. Those things are all true.
All true. A diversity of solutions and approaches to be able to meet people exactly where they are in their journey. So yeah, I love that.
Included this, everyone has mental health journey. These screenings are for your awareness to see where you're at in an ongoing conversation. I love that.
Yeah. How normalizing, everybody gets these screeners. Everybody has a mental health journey. I love that.
Yeah.
All right. Well, we're coming to the end of our time today, everyone. I just want to thank you, Dr. Greenberg. I hope everybody is ready to come back again next Tuesday, same bat time, same bat channel. And if you're not registered for the conference, and this has piqued your interest for more, jump on HMHB's website, get registered for that conference, and yeah, we'll look forward to seeing you all next week. And thank you for making time for this today. Thank you for all of the incredible work that you do improving the lives of moms, babies, and families in the state of Montana and beyond. It is so lovely to see people come and show up and invest time because you want to be better at that work. Fills my cup every single time. So thank you all for that. And thank you again, Dr. Greenberg. We appreciate you.
Thanks for having me.
Heck yeah. We appreciate it. Yeah. Thanks, everyone.